understand it in a way that means something and helps us really take care of patients. Oh, great. Thank you. Figure out how to use it. I have some disclosures. I do work with a lot of manufacturers of immunoglobulin and HAE drugs. But today what I want to do is talk a little bit about the immune system. Now, what is this immune system? Well, it's confusing. And how does it work? And why is it important? So I want to talk about that. Then I'm going to talk a little bit about IgG subclasses and what they are and how we use the information that we learn from them. And then I'm going to turn it over to Dr. Ballow to tell us why this is important in patients and talk about specific antibody deficiencies. So the immune system is a system. It works together as a lot of different parts and moving things. It's not one thing. You can't just say this is it. And so it makes it hard for us to really understand because we have to look at a lot of different parts. And we know that there are things that are very specific, that are very sophisticated. And there's things that are very non-specific and just react to everything. And these things are different, but they work together. So when you talk about the non-specific immune mechanisms, there's a variety of things that help protect us from the world. If we didn't have ways to protect ourselves, we'd be eaten up. We wouldn't exist. So we have evolved ways to deal with the world. So we have physical barriers like the skin, the mucosal surfaces. We have systems that amplify immune responses, proteins in the blood that actually help us initiate and make a response to the world and complement. We'll talk about what these things are. And then there's cells in the immune system that are not specific. They just react to things. Anything foreign, they react to. They don't remember. They don't have any sophistication. They just go, they're soldiers. They go wall things off and keep things from happening. These are phagocytes. Phago means to eat. And natural killer cells, they're natural and they do kill other cells. So they're named appropriately. So complement is very confusing. In medical school, we all struggle to understand complement, but it's pretty simple. I guess the slide has animation that's too quick. See if I can go back and try again. There. So antigen complexes do stimulate the immune system through what's called a classical pathway, and all it does, it activates one protein to become an active compound, to become a complex. And we'll show you what this looks like actually in a picture. But this is the action. This actually does things. And bacteria also stimulate through a different pathway, turn on the same thing, but the end result is turning on this sequence which has a lot of action in the immune system. We'll talk about how that works in a minute. Anything from the outside world has to be kept out of our bodies. So we have all kinds of things throughout that just protect us, starting in the nose and going to the rear end there. So all the way through, there's different mechanisms that just keep things from getting into our body. If you think about the garbage we eat and throw in our body, yet we don't get infected if we have good immune protection. It's pretty amazing. So I'll talk about complement because it's a confusing subject. Complement is very active. This is an accelerant of immune responses. And I love some of these pictures. These are from a National Geographic article many years ago, but they still are very illustrative of what happens. So complement has one function where it serves as what's called chemotaxis. It draws the cells right to the bacteria. So when you have a complement-coated bacterium down here, this macrophage senses it and reaches out and grabs the bacteria. And you can imagine this happening in your tissues. These cells are all over the body. They're very active, and they're really important in clearing bacteria so it doesn't grow into your body. Another function is this terminal complex that we talked about, where you activate complement, and this is the terminal complex. It's actually sitting on a red blood cell. You can see it from the side view. If you look down the barrel here, you can see there's a hole punched right into the red cell, and it'll pop. So this terminal complex actually damages and destroys whatever it attaches to. So that's how your immune system works to kill things, one of the mechanisms. And another is to serve at what's called an opsonin. And we'll talk about opsonins because this is an important concept when we talk about antibodies. But you can see that phagocytes, or the cells that eat things, have receptors on their surface for complement. And when complement is on the bacteria, it sticks on the receptor, and it helps the phagocyte gobble up the bacteria. So it's not a specific mechanism, but it'll gobble up anything that has complement on its surface. So these cells are really important in clearing bacteria out of our system. Now, macrophages are one of the great cells in the blood and in the tissues, and they do so many things. These are factories that produce chemicals that accelerate immune responses. They do an awful lot of stuff, and these are just some of the major cytokines produced, but they produce hundreds of cytokines. Cells respond to these, get turned on, get turned off. That regulates an awful lot of stuff. And we have very few diseases defined by disorders of macrophages. There are some, we're learning about this, but we don't have great tests for them. But this is an important central player in immune responses. Now, if we go over to the other side, the specific mechanisms, these are a little different. These respond to something called an antigen. An antigen is a specific thing on the surface that stimulates an immune response. They're enhanced by prior exposure, so if we give a vaccination and get a response, if we give the same vaccination again, you get a much bigger response the next time. And that helps us in our immune system. When we see things that we've encountered in the past, we remember it, and we make a much quicker, more vigorous response. You can discriminate between yourself and non-self. And that's very important, because if you don't discriminate, you attack yourself, which can happen in autoimmune disease, and that's not good. It conveys memory. Somehow, once you make a response to something, the specific mechanisms create a long-lived cell that remembers that it's responded so that you can respond again, and that protects you from getting the same infection over and over again. Now, when I was taught immunology, we had a B cell and we had a T cell. Life was simple. Well, it ain't so simple. T cells actually help B cells produce antibodies, and T cells also turn B cells off. So they're highly regulatory cells that really interact with a B cell to turn them up and turn them down. T cells also do a lot of killing of things, virally infected cells, cancer cells. T cells are very important in a lot of different things, so it's become very complicated. T cells come in all varieties. B cells are the factory that produce antibodies, and they also produce a lot of cytokines, or signals that turn on immune responses. And this is now a therapeutic target for a variety of autoimmune diseases. It's really important in understanding antibody problems. And again, B cells aren't so simple anymore either. They are exposed to things, and they secrete an antibody, and those antibodies interact with other cells in the non-specific part of the immune system. So they make immunoglobulin, but that works by sticking on different cells. So NK cells can pick up these antibodies and be more directed in their function. Same thing with macrophages. Since they're non-specific, then the specific part of the immune system interacts by antibody. Neutrophils have receptors for these. B cells actually have downregulation from antibody. And mast cells can cause allergies with IgE binding to them. So the B cell makes antibody, which interacts with the whole system. And now B cells, we know, have different types of maturational steps, and we can find defects along this. This just is confusing to look at, but what it is, it's different markers on B cells at different states of maturation. And what we find is that some people can't fully mature their B cells. And if you don't, you can't remember that you responded to something. So you have problems remembering and fighting infections, and you get the same infection over and over again, which happens in immune deficiency. So now we're actually looking at phenotype, or the picture of what the B cells look like in the blood, and we can identify these types of markers, which has become a very useful tool. Now, as I said, B cells and T cells love each other. They talk to each other, they hug each other, and that's how they make responses. And these interactions are really important. So T cells, will help B cells make antibody, like we talked about. They suppress the production. They turn on the macrophages. They hit other cells to make them become dying cells. This is important now in cancer immunotherapy. So it's become a very central player. The T cells are really the king of the roost. And T cells also have become very complicated. There's a whole variety of different regulatory functions that T cells have, and they're created by different cytokines and signals. So it depends on the environment they're in, how this matures, and what kind of immune response happens. So for us to figure this out is no longer just looking at a B cell or a T cell. It becomes quite complicated. Okay, enough of this boring stuff. Let's talk about IgG subclasses. Okay, this is just a simple illustration of what an antibody looks like. They have these two big heavy chains, they're called, and they have two of these little light chains. And that's just a basic structure of antibody. Out on this end here, we call it FAB, but this is where there's specific binding to whatever that antibody is made against. So every antibody molecule has its own binding site. And then there's something that's in common with all the antibodies in our body, and that's this part, the Fc portion. This is sort of a key that turns into signal cells, and it's a really important functional part of antibody. And all of our antibodies have this Fc tail. Then you have something here which is sort of like a spring. It's a group of molecules that help the molecule bend in ways and do stuff, bind complement and other things. This is actually a picture of antibodies. You can see they actually look like the Y. That's an antibody there. So that's the basic structure of all of our antibodies. And we have different classes of antibody, just so we know which one we're talking about, and they have different functions. So IgM is the first antibody. When you first see a new thing, you make an IgM antibody. And this is actually 5 different antibodies stuck together. And it's a big molecule. IgG is the memory antibody. After you make an IgM response, the cell switches internally and produces IgG to the same thing that this IgM was made against. And we'll make that for a long time. And this is a simple antibody molecule. IgA, it's in all of our wet surfaces of our body. This is secreted. And it's actually 2 different antibodies stuck together by a secretory piece and a J piece. It joins these 2 together. IgE, this is not a good antibody. This causes allergic reactions. And you don't want to have a lot of that. And then there's IgD, which regulates a lot of stuff in the immune system. It has very low levels in the blood. So there's different classes of antibody. And if you look at the distribution in the blood, most of the blood antibody is IgG. Then this is all in the wet surfaces. But if you don't count the wet surfaces, just look at the blood, it's about 15%. This is probably the largest amount of antibody in our body, though, when you take the bowel and the lung and everything into account. And then there's a very small amount of IgD, and most people that aren't allergic have very low levels of IgE. You see it high in different immune disorders or in allergic conditions. Now, if you take that IgG fraction of the blood, we see that not all IgGs are exactly the same. They differ. They have different spring areas in them, different sizes. So they look a little different, and this matters because they have different functions. So even though they're all IgG class, we give them subclass names so we know which one we're talking about. And if you look particularly at the IgG3, it's got this long spring area. And that makes it function differently, and it makes it last in the blood a shorter amount of time. So the half-life of that IgG3 is shorter than the rest of them. This just shows some of the differences between the subclasses of antibody. You can see that most of our IgG is IgG1, and then IgG2, and then very little of it is IgG3 and 4. So there's different amounts of it. A half-life of it is 23 days for most IgG. However, very short half-life for IgG3 because it's got that long spring in it. Complement binding, well, this is why there's a long spring in IgG3. It's very efficient at binding complement, and that's really important for immune function. We're going to talk about that in a minute. Going across the placenta, most of the antibody is IgG1 that goes across. But a baby is born without the ability to make much antibody, and you need the antibody from mom to go into the baby to protect the baby. And then binding of monocytes, there's different type of binding to other cells. So this distribution is important and is something that we look at when we measure IgG, because if you measure IgG alone, you might see a normal IgG level, but when you look at the subclasses, maybe it's all IgG1. So it's not really a normal distribution, and you're not going to have normal function. That's unusual, but it happens. And these are where the Fc part, the tail piece of the IgG, sticks onto receptors. And these are like keyholes, and the IgG tail sticks into this and does different things to populations of cells in the body. And so these are the different receptors. Some of them are inhibitory. When they bind, they actually turn the cells off. Others turn them on. Some actually give signaling internally in the cell. This is like a cell membrane here. And some actually engage with other molecules. So the tailpiece is a very important part of an antibody and has a lot of functional importance with different diseases. And this just shows what happens in an infant. This is the concentration of antibody, and this is age. So when a baby is born, this is the baby's IgG production. There's very little antibody being made in a baby. It's almost all coming from the adult, the mom. And as that antibody degrades over time and falls off, the baby's is starting to come up, and the total amount in the blood will reach a bottom, a nadir, right about 4 months old. And that's often when we start to see a baby that can't produce antibodies start having infections, because they're losing the protection from mom. So what's happening here is if the antibody is being produced in the baby, it'll dip and it'll come back up. So levels of antibody do change as a baby matures. Okay, so why is this so important? Well, I use an analogy. This is a dried up meatball sitting there. Doesn't look very appetizing. No one wants to eat it. But if you take and you put some nice spaghetti sauce on it, and all of a sudden it looks appetizing. This is sort of what we think of when we think of opsonins. When the immune system's presented a bacteria, it doesn't have a lot of interest to get rid of it. It's not until it's coated with something that the immune system gets interested and eats it. So to talk about this, we have different opsonins. And so when you have a macrophage or something that's going to eat the bacteria, which is like our meatball, if you have no opsonin, there's not a whole lot of eating that goes on. It just isn't interested. If you take and put this phagocyte, it has receptors for complement there, and your opsonin is complement only, you do clear the bacteria out of the blood. It's pretty efficient at eating, not great, but pretty good. If you take just antibody and take those receptors I talked about, those Fc receptors, and the key piece on the IgG, coating the bacterium, you get some eating of it. But if you put the whole thing together and you have complement and if you have complement and antibody on the surface of the bacteria, you actually get very, very efficient clearing of bacteria. So the phagocyte eats it up. It loves it. So it's like you put good spaghetti sauce on instead of just partial coating of it. And when you look at an animal model, this is an interesting study. This is percent of bacteria that survive when you inject them into an animal, and this is time in hours. So the first situation, they take an animal, take bacteria, and they inject it into the animal and just watch its survival. And this is where there's no opsonins at all. So this is an animal that has no antibody and no complement. And the bacteria just hang out and live there. They don't die. So if you take and put IgG on the bacteria, I guess this is the bacteria without any opsonin on it. You take bacteria and put IgG on the surface and then inject it, it's cleared out of the blood pretty good. If you take bacteria with IgG and complement on the surface, it's dramatically cleared. In 2 hours, it's gone. So that's how these things work together to make things more efficient. So if you're missing something in your immune system, it's not all or none. It's qualitative. It's how well and how efficient you are at functioning. Now, when we look at types of infections and the types of bugs that people get, it helps direct us in our thinking as to what's wrong. So when we take a history of an immune deficient patient or a suspected immune deficient patient, a lot of times we try to find out what bugs have caused their problem, and that helps us hone in on what part of the immune system might be wrong. So this just shows the type of defect and the type of bugs that we see that cause infection. So if you have antibody or mannose binding lectin that's deficient, you tend to have infection with these types of bacterium. If there's a T cell problem, you tend to have viral infections, yeast, and unusual organisms that cause infection. Complement or mannose binding, you get different types of staph and Neisseria meningitidis. These are bacteria that are unusual with antibody problems. And then neutrophils, if they're deficient, you get skin bugs and whole select things. So we actually can hone in on what part of the immune system to look at based on a history. Now, if you go to the antibody deficiencies, which are pretty common, let's just reiterate what we were talking about with the opsonins and the receptors. But when these things are defective, we don't get weird, unusual infections. We get common infections more commonly. And that's a concept that we try to teach doctors in training to think about, because normal immune people, they get an infection, sure. They get treated, they're better, they're fine for a long time. People with immune problems or antibody problems, they get infected, they're treated, they're better, and then as soon as you stop antibiotics, the process starts again, and within a short time, they're infected again. It's a different pace of infection, but it's not unusual stuff. It's sinus disease, ear infections, sometimes bronchitis or pneumonia or cellulitis. So these are common things that happen, and if a doctor doesn't have a history or know you, they don't realize the pace of infection. So you go to urgent care, they don't have any clue that you were in a month ago and a month before that. So it really takes looking at the perspective to help you think about having an immune deficiency. We see a lot of problems in antibody deficiency handling bugs that we call encapsulated. These are bacteria that protect themselves by putting carbohydrates or sugar molecules on their surface. It's like a fuzzy tennis ball. And I'll show you a picture. This just shows if you're missing. This is a picture of a pneumococcus. This is the bacterial wall here, and you can see this fuzzy stuff on the surface. That's carbohydrate. And here's the carbohydrates, touching each other. And this protects these bacteria and makes it more difficult for us to get rid of them. So encapsulated organisms is the term we use for that. Now, if you have difficulty handling these types of bacteria, you end up getting different types of infections. Here's a normal side of sinus that has air in it that's black. This side has no air in it. It's full of pus. And that's a bad sinus infection, very painful. Many of you probably know what this feels like. A common problem also is pneumonia, and this is a lobar pneumonia. This is all white because it's filled with pus and infection. The rest of the lung is pretty clear here. So this is another problem that happens with pneumococcus in particular. This is something that brings back memories to me. I trained in pediatrics, and when I went through training, it was before we had vaccination for Haemophilus, and every night we'd go down and have to tap babies with 104 fevers, and you look under the microscope, and this is what we'd see. It's Haemophilus influenza. When a vaccine was introduced, all of a sudden that went to nothing. I don't think our residents even know what this looks like anymore. So it's really nice to see that when we protect people with antibody, they don't get this. Well, if you don't make antibody, you don't have that kind of protection. So it's interesting to see that. And then lastly, this is also something we'd see a lot, and this is a cellulitis around the eye. You can see how puffy it is, periorbital cellulitis. This is something we hardly see after the vaccine program. So it's been nice to see that kind of improvement, but we used to see this all the time. And again, the common bugs are these, and these are the common types of infections. Okay, so it is important to have antibody and opsonin. So now what? Well, we could switch a little bit over and talk about primary immune deficiencies. When there's something wrong in the system, what does it look like and how do we deal with it? So we talk about primary immune deficiencies as those that are usually genetic. You're born with a defect in your cells. And I like analogies. If you're sitting out in space and you're looking at factories in the United States and you see they're making cars, and what you see is this factory makes 10 cars a day, this one makes 20, this one makes 5, this one only makes 1. Well, there's something wrong in the ones that make very few cars compared to those that don't. Now, it could be one little gear inside of one machine in that factory that slows the whole production down. And that's sort of how it is with immune deficiencies. We're looking at a result of a whole lot of things, and we're trying to find what gear it is that's broken. Secondary immune deficiencies are from infections like HIV, malnutrition, immune suppression, chemotherapy. Huge amount of stress can affect your immune system, and these are secondary. We heard this morning from Dr. Torgerson that we have now over 320 genetic bases for immune deficiency identified. And are these actual diseases? Well, they can look very, very much the same. So you get a multiple genes that make the immune system look the same way. So it makes it confusing. Some immune deficiencies are very common, and some are quite rare. Diagnosis and treatment really is not simple. So it's good to find a place, and most of you have been diagnosed that are here. You've found somebody who understands the immune system and has been able to get to the bottom of it. But until you do, a lot of times people flounder around trying to find help, and they can't. And they can't get it. So it's estimated, and this is old data. This is from the IDF survey back in 2007. But it's estimated there's probably, more than 250,000 people diagnosed with PIDD. And there's probably well over double that are undiagnosed. I think it's probably much more than we know. And the incidence is pretty common. But the thing that bothered everybody was this. Usually takes about 12 years to get a diagnosis on average. Now that's come down, but not as much as it needs to. So we're picking up immune deficiencies earlier, but it still is way too long for people to find an answer. Most people are diagnosed early if they have severe, but if they have mild, they aren't. So the overall is only about a third of patients with immune deficiency are picked up early. And about half are diagnosed by 30. We're learning that adults are presenting with genetic immune deficiencies. And it's a lot more common than we ever knew. So we really don't know a lot about adult onset immune deficiency that's on a genetic basis. Okay, primary immune deficiencies, you can see most of them are antibody deficiencies. And some are both T cells and B cells involved, so they're combined. Then you get into the phagocytic diseases, and then very rarely do you have complement disorders. And then you get these that are primarily cellular disorders. So most of the immune deficiency we see affects antibody production. And so antibody is really a key when we think about treatment, because antibody is affected by most of these immune deficiencies. Okay, so these two zebras are walking down the road, and one says, I have subclass deficiency. And so no one knows what that is. Is there really such a thing as subclass deficiency? Well, it's debated and it's argued amongst immunologists whether this is really important or not. And I think there's differing views. So let's talk about what it is. Primary immune deficiency disorders often have abnormalities in IgG subclasses. So just by looking at the subclasses, you might be missing what's really going on. So some subclass deficiencies may be important if you look at the whole picture. You can't just look at the subclasses. So if you have IgA deficiency, it's very common to have 2 and 4 subclasses low in IgG fraction. Common variable, you might have all of them low. Wiskott-Aldrich syndrome, it's really IgG3 that's low. Ataxia telangiectasia, you have some off subclasses. and then in other disorders, there's different. So the subclass deficiency alone isn't the problem. The subclass deficiency is a result of something wrong in the way you regulate antibody production. So you have to look further to make any sense of this. Now, we use codes because insurance companies like to keep track of things. There's actually an ICD-10 code for selective deficiency of subclasses. So it is a primary immune deficiency in the eyes of the insurance industry. It's identified as one or more subclasses that are low, but it never provides a definitive diagnosis, and it must be considered as a disturbance. So this is really important to understand. Misdiagnosis of subclass deficiency as a cause of immune deficiency is common, and it leads to overuse of immunoglobulin. So this is something we talk about. How many patients are really on immunoglobulin because they have low subclasses, but that wasn't important in their clinical picture. So we have to define this further to really know what to make of a subclass deficiency. So is it important? Well, like I say, maybe. It's a clue there's something wrong, and sometimes it is very important. You need to interpret it carefully. You need to identify comorbidities. So are there other things leading to recurrent infection? And maybe it's not just the subclass that's low. You have to think about specific antibodies, and Dr. Ballow is going to tell us about this and why that's so important when we're evaluating someone who might have a subclass deficiency. And the outcomes of these deficiencies is hard to predict. It's generally pretty good because you have a number of different ways to treat these that are quite effective. But you might not need as much as you jump to. It's just nice to know you have all these options. So if you diagnose a child under 5 years of age with a subclass deficiency, we often watch because as they mature, as they reach about 5 or 6, a lot of times things recover and they make better quality antibody. So it isn't an all or none. It's something that is a maturational problem in some individuals. Now sometimes you have subclass deficiency and it goes on to develop a more serious problem. It could be the beginning of a common variable, and over time the antibody levels fall or change. And so we need to monitor these over time. It's not just a one-time thing. And it's very hard to predict who's going to go on to have more of a significant immune problem. So we don't just make a diagnosis and say, hi, goodbye. You know, we need to follow these things and see really what happens. And patients encountering infection and how they handle it tell us an awful lot about what kind of therapy we need to do. We don't know the inheritance for most of these. Males and females have this very much about the same amount. There's individuals with IgG subclasses that are found in the same family. So you might have siblings, but this isn't the norm. It's not always the case. So we really don't understand the inheritance pattern. Some families have different types of immune problems. So one person has just IgG subclass deficiency, and another has IgA deficiency, and another has common variable. In the same family, probably from the same gene, but there's modifying factors. This also needs to be figured out better. And there have been chromosomal deletions of the heavy chain of Ig that result in total lack of one of the subclasses. But that's rare. So it's confusing, and even doing genetic analysis, I don't think it's clarifying really what we see. So how do we manage it? Well, once you identify someone and you think that the subclass deficiency may be related to their recurrent infections, I go through a list of things, my list of 7, things that might contribute to recurrent sinus infection. And if we address those and we still have infection, then we need to do more. So you look at reflux. That's one of the most common causes of recurrent sinus disease. People lay down at night, they have acid reflux, they get secretions in their nose, and they wake up and blow their nose all morning, and then it clears. This is a common problem. You address that, and it may help the sinus symptoms. Environmental things like allergies, molds, irritants, they all cause secretions in the sinus. And those are food for bacteria and may lead to infection. Structural problems like the sinus passages, sometimes structurally they're abnormal. Sometimes kids put things up their nose and it sits there and blocks, and that can lead to chronic infection. There's a lot of things you think about structurally. Immune problems like qualitative defects that Dr. Ballow will talk about have to be thought of. And then there's genetic disorders of mucus like cystic fibrosis or cilia that move the mucus. And then there's the idiopathic group. And rarely do we come up with the idiopathic. That means we just don't know, but people still are getting infected. And it happens, but it's more common to identify factors here that contribute, and sometimes it is the antibody. So I start with antibiotics. We use prophylactic antibiotics. These can be very effective in people with recurrent infections, and sometimes that's all we need. Other times we do on-demand, where if someone has recurrent sinus disease, we know they do, after 3 days of progressive symptoms, we'll treat them. And that seems to help people live their life with predisposition to infection and isn't dangerous. It helps get on top of it. And then sometimes we can't handle it with the antibiotics alone, and we do replace some of the antibody with intravenous or subcutaneous immunoglobulin replacement. And this is extremely effective in people that fail the simple approaches. So that's sort of a basic management of this. So sometimes you think you have low subclasses, and that's the problem, but a lot of times you're barking up the wrong tree. You have to think more what really is going on, because there's probably more than just the subclass deficiency that's really causing the problem. So at this point, I want to turn over to Dr. Ballow, who's going to tell you something that really matters.
Well, thanks for that introduction, Ralph. That sets the ground rules very nicely. So before I show you any slides, let me tell you a little bit of historic kind of transition from IgG subclasses to selective antibody deficiency. We actually have just recognized it with an ICD-10 code. If you look at the old system, and these are, you know all about codes, I'm sure, but the old coding system was ICD-9, and there was no code for selective antibody deficiency. There was for IgG subclass, but not for selective antibody deficiency. So it's finally recognized as an entity among the, what I call, third-party payers, hospital administrators, the suits, I don't know how you want to refer to them. At any rate, if you go back in the literature in the 1970s and 1980s, IgG subclass deficiency was a hot item. In other words, it was recognized that there were patients who had recurrent upper respiratory sinuses, ear infections, and lower respiratory pneumonia that had IgG subclass deficiency. Sometimes with hypogammaglobulinemia or decreases in total serum IgG, and other times normal levels of serum IgG. It just depended on which subclass was decreased. And in fact, if you look in a ENT clinic, and there's literature for this, you can probably find about 18% of patients who have recurrent sinusitis has IgG subclass abnormalities. And as Ralph pointed out, there's a little bit of controversy. So are they abnormalities? Are they deficiencies? Are they just variations of normal? And that's what the discussion is all about. It was also recognized in some of the older literature that those individuals who had IgG subclass deficiency, particularly IgG2, did not make antibodies very well to certain bacteria and certain vaccines. That is, those that Ralph pointed out as encased or encapsulated by polysaccharides, like Haemophilus influenza, Streptococcus pneumonia, Moraxella catarrhalis, etc. And so there was this recognition that that different IgG subclasses tend to make antibody with certain types of bacteria. So IgG1, for example, tetanus antibodies tend to fall into IgG1. Antibodies to certain viruses like RSV, adenoviruses tend to fall into IgG3. And antibodies to the polysaccharide-coated bacteria tend to fall into the IgG2 subclass. So it became very popular then to try to correlate what types of infections patients had with, or vaccine responses with what kind of IgG subclass deficiency they had. But there was also another study where Penny Shackford, if you remember that paper, Ralph, looked at a number of normal blood donors coming into the Red Cross. And she found that, there was a significant number of individuals, normal subjects, who were donating blood that had IgG2 levels that fell outside the normal range. But yet they made antibodies normally. So that brings me back to the concept, and I had a slide on here, and I don't know if I gave it to you, but anyway, you didn't show it. But anyway, if you look at the quantitative values for the IgG subclasses, the labs give you a normal range. It's the 95% confidence limits. And if you plot that out, it's a bell-shaped curve. So obviously the bell-shaped curves that most people fall in the middle. But that means there are normal people that fall at the upper end and other individuals that fall at the lower end. So 2.5% and fall outside this range, this 95% confidence limits that the commercial labs have set up as, what is normal, what the normal is for IgG1, IgG2, IgG3, and IgG4. So, so that means, clearly on a statistical basis, there are normal individuals that fall into the lower range, 2.5%, and the upper range, but yet they're normal because they can make antibody naturally, normally, and also to vaccine responses normally. And that's the transition that we get into when we're really talking about selective antibody deficiency. What is selective antibody deficiency? And my colleagues and I call it SAD, S-A-D. And that is the inability to make specific antibody, in this case, to polysaccharide-coated bacteria, like strep pneumonia. And that's why we use the vaccine, Pneumovax, that's the commercial name, which is a vaccine against 23 of the different subtypes of strep pneumonia. We call them serotypes. That's just a name that we put to it. And therefore, we use this vaccine to evaluate patients for their ability to make specific antibodies, whether or not their serum IgG is normal or whether they have IgG subclasses that are outside this 95% confidence limits. Okay. All right. So let me start with the slides. That's kind of like a little bit of an intro. These are my disclosures. I interact a lot with the different commercial gamma globulin products. I'm also on data safety monitoring boards for new products that are coming out. So we'll do this by case, just to kind of give you a flavor of what Dr. Shapiro and I, how we kind of approach patients that are referred to us with recurrent infections. So this is a 4-year-old who was referred to our practice with the following history. At 8 months of age, had recurrent otitis media. It resolved after age 1, after they placed PE tubes, and they took out the adenoids. So that's good, and that's not uncommon. At 18 months of age, started again to have recurrent and chronic sinusitis, but no pneumonias. An allergy evaluation did not reveal any atopy or allergic abnormalities like allergic rhinitis or asthma, etc. And that's one of the really important issues that Dr. Shapiro was pointing out when he talked about underlying comorbid conditions that may contribute to recurrent sinus disease. Obstruction, we talked about obstruction, and also allergy, which is very common. Now, the serum immunoglobulins were normal, so we go beyond that. We want to know whether that 4-year-old can make specific antibodies. So we check for tetanus, and of course, they get all their childhood immunizations, so the tetanus antibodies were present. Every year, usually kids also get influenza vaccines, so we looked at influenza antibody responses, and they were normal. And then we looked at pneumococcal polysaccharide antibody responses, because we know that 4-year-old has undergone immunization with Prevnar, that's a conjugated pneumococcal vaccine that they get early in life. And in this particular child, it was only positive to one of the serotypes. Remember, a serotype is a certain subtype of the strep pneumonia or pneumococcus, and we called it a serotype. Different physicians measure different numbers. I'll just mention that now. There are certain labs in which we can measure 23 different variations or subtypes or serotypes. I know one lab, like LabCorp, unless they change, only measures 14. We measure 23 because that's what's in the Pneumovax. And Pneumovax has 23 different variations or subtypes or serotypes in it. So that's why we measure all 23. Anyway, this 4-year-old only had one positive, even though that patient had been fully immunized with Prevnar. And you have already seen a sinus X-ray before, and I think we can just breeze past this, but this child has pretty much chronic pansinusitis involving a lot of sinuses, ethmoid and maxillary. At any rate, so we immunized this patient, and the response was only 2 of the serotypes became positive. So you can see this was at baseline. And what is protective? Protective is anything greater than 1.3 micrograms per ml. There's a lot of history to that. I'm not going to get into that unless people have a specific question. But we look for changes. We look for at least a 2-fold increase in the baseline titer, or going over 1.3. So, for example, here, the baseline titer for this particular serotype 9N was 0.07, and it went to 2.31. So that's a good response. That's an adequate response to that particular serotype. Again, type 14, it was also in a protective range. So I know there's some subtle nuances in interpreting these pneumococcal responses, and each clinical immunologist may actually have a little bit different take on how to interpret, and there's a lot of controversy in this whole area. But suffice to say that this 4-year-old who should respond to the Pneumovax, and by the way, we don't immunize with Pneumovax until after the age of 2. I'd rather not do it until 30 months of age, because children younger do not respond very well to pure polysaccharide type antigens. They respond to proteins great, like tetanus, but not so much to polysaccharides. So that's why we, with a younger child, we'll tend to hold off and not to confuse the issue, because if they get a subnormal response, we don't know whether it's an inadequate response because of their immune deficient or whether it's an inadequate response because of their age. So definitely we wait till age 2. I tend to wait till they're age 30 months. But a 4-year-old should respond, and this child did not respond well at all. So this is a typical diagnosis of selective antibody deficiency. Normal immunoglobulins, subclasses not even evaluated, because really the issue here is, can they make specific antibodies? And you can see that this child did not make antibodies very well at all, following pneumovax or pneumococcal polysaccharides. So the decision was made to place the child on immunoglobulin replacement therapy. In this case, it was subcutaneous. There was a discussion between the parents and the physician. And then we decided to take the patient off April, May, depending on where you are. Maybe it's a little bit different in Minnesota, but we take them because in the summertime there's just less contact. The kids are not in school, or maybe in daycare they're more outside, so there tends to be less infection around in the summertime. So it's a good time to take patients off. You want to reevaluate them and then to determine whether they still have this type of immune deficiency. So this patient was taken off during the summer and then reevaluated subsequently to determine whether the immune deficiency, the selective antibody deficiency, was still there. Why do we do this? Because it turns out that at that age, and I have lots of patients referred to me with chronic upper respiratory tract infections, some with and without underlying allergies, who have this kind of deficiency in the production of antibody. They have selective antibody deficiency that outgrow it. So it's, in my mind, it's not real immune deficiency, it's more of a developmental immune deficiency. Because a lot of these kids I don't see back at 7, 8, 9, 10 years of age. So at any rate, it's certainly worthwhile to do this once, is to take them off gamma globulin if they've been on during the summer, and then reevaluate, in this case, re-administer pneumovax and look at their responses again. So Jordan Orange and others on his committee have published their perspective on selective antibody deficiency, and they've divided up into 4 different kind of categories, from severe, in which there is almost no response following pneumococcal vaccine, to those that have a mild type of selective antibody deficiency in which there is some response to many of the different serotypes or subtypes of the pneumococcal polysaccharide vaccine, but perhaps not as robust as a normal individual. And these numbers, you can see numbers less than 70%, less than 50% as far as being abnormal, is very controversial. So, for example, if a child is under 6, we expect at least a 50% response to the pneumococcal vaccine serotypes. So there's 23 in the vaccine. So we expect at least 12 or 13 that are in the protective range. That's what that means. In an adult, we expect 70%. But that's not a number I use. I don't know if Dr. Shapiro uses that number. That number was generated by a consensus of our colleagues, and some of us don't necessarily agree with that. That number is kind of high, less than, in other words, in order for an adult to be abnormal, they have to generate less than 70% of antibodies to different serotypes. And I think we can have a discussion about that later. But at any rate, that's what's in the literature, and maybe your clinical immunologist has mentioned that number to you. That's why I bring it up. Now, I want to just spend a couple minutes, let me see, make sure we have good time, a little bit about the last phenotype. It's called the memory phenotype of selective antibody deficiency, and I want to give you an example of that. So this is a 5-year-old who, again, has recurrent upper respiratory tract infections with sinusitis. He was well until about 2 years of age when he started to have these episodes of infections treated with antibiotics. Sinus CT scan, again, shows, chronic sinusitis. Allergy evaluation in this case was positive. He was allergic to pollens and also what we call perennial allergens like dust mites, and they had a cat in the house. They had to get rid of the cat, yada, yada, yada. And he was treated initially with prolonged antibiotics and also treated rigorously for his allergic rhinitis, in which we use antihistamines and topical nasal steroids. And in fact, this would be a perfect patient type to also put on immunotherapy, allergen immunotherapy, desensitization, allergy shots, because we've identified. At any rate, despite rigorously treating his allergic rhinitis and using antibiotics, he continued to have problems with sinus infections, so we performed an immune workup. His serum immunoglobulins were normal. He had specific antibodies to the protein vaccines, like tetanus, and also following influenza vaccine, and Haemophilus influenza type B, which is a conjugate vaccine, by the way. And but his baseline antibody titers to the pneumococcal polysaccharides were low, even to the Prevnar serotypes that he had received, because he was fully immunized. So again, we gave him Pneumovax, and you can see his response here. This was baseline. His response was very robust. It was great. And in fact, his parents came back and said, after he got the Pneumovax, he did fine. He had less sinus infections. We didn't have to put him on antibiotics. But then about 5 months later, he started to have sinus infections again. And so we got another set of titers to the pneumococcal polysaccharide antigens. And you can see that here he was 4 weeks after getting the Pneumovax when we initially evaluated him, and this was 6 months later, and you can see a lot of the titers really fell off. He still had positive titers, 4 out of 14 in this particular case, but he failed to retain or maintain a lot of the original titers after the Pneumovax. And this is what we call selective antibody deficiency with the memory phenotype. Their immune system has a short-term memory. It falls off. Now, you could try giving a second pneumococcal vaccine, although there's some caveats to that too. Some of the infectious disease individuals are worried about invoking non-responsiveness or tolerance to the vaccine, so we tend not to do that closer than 1 year apart. We don't really know what the etiology is, but Dr. Shapiro mentioned memory B cells. He showed you that complex slide of different B cell subtypes, and in that gemisch of the different B cell subtypes, there's a certain type of B cell called a memory B cell, and we can identify that by its surface characteristics using flow cytometry and monoclonal antibodies. Well, these patients with selective antibody deficiency tend to have a decrease in these specialized memory B cells, which we believe need to be there in order to sustain this antibody response either after natural infection or following a vaccine response. So what do we do as far as therapy? In these patients with more mild selective antibody deficiency, such as this particular patient, we would first go with using prophylactic antibiotics. Which ones? Septra or Bactrim or azithromycin are two that I commonly use. Maybe Dr. Shapiro uses others, or other immunologists uses others, but those are what I use. So just kind of in summary, specific antibody response, the gold standard for any patient with an antibody immune deficiency is their capability of making specific antibodies either naturally, for example, following natural infection, or following vaccines administration. And I just showed you kind of an example of what we go through with strep pneumonia or pneumococcal antibody vaccines such as Pneumovax. What are some of the vaccines that are available in order to evaluate or test this? We certainly look at specific antibodies to tetanus and diphtheria, particularly in patients that we're evaluating for another entity called common variable immunodeficiency or other immunodeficiencies such as combined immunodeficiency. We talked a great deal about pneumococcal vaccines that fall into two different groups, the conjugated ones, and what I mean by conjugated, they have both the polysaccharide component of strep pneumonia or pneumococcus plus a protein component, and the protein component I think is diphtheria if I remember correctly, or Pneumovax, which is just a native polysaccharide component. Haemophilus influenza, which is conjugated now, so most patients with mild antibody deficiency respond great to this particular vaccine. The meningococcal vaccines, the one we use now is available, again, is conjugated. We don't use that as a test vaccine, although I guess we could, because most certainly adolescents get the meningococcal vaccine as a normal course now. So I guess we could use that, but we don't have very much data to look at that. There are some unique type of vaccines. The Seattle group, for example, has available what we call a neoantigen. It's called FIX174, which is not available to anyone else, and they use it more on a research basis. Another type of vaccine that could be useful, and we may actually see more information in the future, because I know Dr. Orange is working on this, and that's vaccine to rabies. The rabies vaccine has been around for a long time. In fact, it's a better vaccine now than what it was 10 years ago. And so, again, we don't have very much information on what normal responses are like in normal subjects and how we can employ this vaccine in patients in the evaluation for an underlying immune deficiency, and the same with the Salmonella typhi vaccine. All these vaccines, whatever we administer, we always look at the immune response at a certain time frame, 4 to 6 weeks after immunization. So occasionally as a clinical immunologist, we run into problems where patients get the vaccine and then we don't see them again for 3 months. And then, we try to evaluate the response after 3 months, and sometimes it can get very messy to try to do that. So just as a kind of a aside. Let me skip this. So some patients may warrant prophylactic antibiotics, where others may warrant immunoglobulin replacement therapy, and it just depends on the clinical course of the patient, which systems are involved. For example, is it just upper respiratory, or is it both sinusitis and lower respiratory like bronchitis or pneumonia? And whether there's any other comorbid conditions present as well. So particularly with the mild phenotype, we tend to gravitate towards prophylactic antibiotics first, and then to see how that goes. And even those patients, for example, with a memory phenotype, we may elect to put on replacement gamma globulin if they fail prophylactic antibiotics. So let me stop there, and we'll have an opportunity to do Q&A to answer some of your questions.
Do you want to read them, actually? And then we'll answer?
Sure.
That's probably to be clear then.
Repeat your phone. Okay. Has everyone passed up their cards? Okay.
read it and we'll figure out who's going to answer it.
Okay, absolutely, I can do that. Okay, so we're going to go ahead and I'll ask some questions because we still have some time to answer quite a few questions. So here's the first question. Is there a relationship between SAD and IgG3 and Crohn's or autoimmune? Is this kind of a development that's indicative of development of CVID? Is there a relationship between SAD and IgG3 and Crohn's or autoimmune? The first.
Yeah. Well, I think this touches on what Dr. Shapiro and he can embellish this. Is that some of these patients may transition between selective antibody deficiency / IgG subclass deficiency into common variable immunodeficiency, where we know that there can be other conditions or autoimmune conditions in particular that are associated. I don't have any data for autoimmunity and selective antibody deficiency. I have not seen that literature, so I can't comment on that. But I think
It's an interest of mine because I notice I do a lot of autoimmune work too, and IgG3 isolated being low, no one really talks about it as an entity, but I find it in people that have other autoimmune disorders. How it's related, I really don't know. I haven't seen anyone that studied it or looked at it very carefully, but it is one of the low subclasses that when I see it, I think, is there autoimmunity somewhere? So I think there's some relationship there.
Okay. This question actually touched on what I had just mentioned before about the memory phenotype. Remember where patients lose their pneumococcal antibodies after a certain period of time prematurely. And the question was, will they benefit from B-cell phenotyping? And yeah, I think that can be a useful assay. But we get pushback by insurance companies for ordering because these are done in specialized labs. For example, the lab that I use to do this particular assay, there's B-cell subtypes, including the memory phenotype, the switch memory phenotype. I use Mayo Clinic in Rochester, Minnesota. And we often can't get it approved by the insurance company, so that's kind of a barrier.
Yeah, we've been using it for some time. Mayo Clinic is 100 miles away, and we have a shuttle, so it's easy to do. And we've not had trouble with insurance covering it, actually, and I find it helpful. Where it really helps is when you have to argue with an insurance company to get immunoglobulin available for someone who you believe needs it. It's been helpful to demonstrate the issue. Now, there's probably many genes that lead to the lack of development of a memory B cell, and so we still don't know the genetic disorder, even if you identify low B cell memory cells. How are we factoring the tendency to be more easily able to develop lymphoma as CVID patients? So what's the relationship between CVID and malignancy? Are we more prone to autoimmune disorders? And what should our IgG test levels be? And more with bronchiectasis. So there's a lot of questions here about CVID. We know that individuals with immune problems, no matter what they are, have a higher risk of cancers. Now, that doesn't mean it's high and you shouldn't freak out and worry about it, but you have to be aware of it. And that makes sense, especially leukemia and lymphoma, because the cell that makes antibodies is a lymphocyte, and a lymphocyte, when it's broken, can make mistakes. And why it happens, we don't know, but that is what we see, is that people with lymphocyte disorders tend to have an increased risk of lymphoma. Now, there's also viruses that impact on this, and especially the Epstein-Barr virus that causes mononucleosis. Sometimes that can create a situation where the lymphocyte gets out of control and grows. It looks like a cancer, but it's not a cancer. So that's another problem that we see occasionally in immune deficient patients. So these are all problems because the immune system's broken. I don't know if you want to talk about that, or we can talk about some of these other issues here. Prone to autoimmunity, the same thing, that the immune system is broken. It makes mistakes, and we do see a lot of autoimmunity in some types of common variable, but not all. So, and this is interesting, if you look at the B cell in a lot of common variable, the B cells don't die naturally, and they tend to accumulate. So you get a lot of cells that should be taken out that might be autoreactive. That's my simple way of looking at it, and we do see autoimmunity frequently in a common variable. So you have an antibody deficiency, yet the antibody's hurting you. So it's kind of counterintuitive, but that's what we see.
Okay, this has come to our attention, the IDF attention recently. Maybe the person that wrote this question actually sent an email to the IDF. And that is LabCorp has changed their normal range for IgG subclasses. Each lab generates their own normal range. Remember I talked about the 95% confidence limits, bell-shaped curve, 95% confidence limits. And so each lab generates their own normal range. And I'm not sure why LabCorp changed their normal range. It may be that I would guess that they changed the methodology. There's many different methodologies to measure IgG in the serum. And I'm guessing what happened is they came up with some other automated method, maybe using immunobeads or some other method. So they went back to generate their normal range. It is what it is. That's their normal range using that particular method. But the bottom line is, again, as I said before, the gold standard for an immune deficiency, even if you have an IgG subclass, is whether you can make specific antibodies. So that's really the bottom line, the gold standard. So, yeah, LabCorp changed their normal range. There's nothing we can do about that. But I hope that individual understands that what we as clinical immunologists is looking at is not only the protein value of that particular IgG subclass, but whether that individual is capable of making specific antibodies. I'm sorry? Do I know? Yeah. No. And this is a short one. Is IgE always bad? Because it only causes allergies? Does it have any good things? Yes. Actually, it may help us with parasitic disease.
It's probably an evolutionary antibody that was used when we didn't have other ways to handle infection, and it's still a remnant, sort of like the eosinophil. So we see it when it's difficult to get rid of things, but certain types of immune reaction will switch over to make IgE in a higher amount, and that actually causes us problems. What does conjugated mean? There's multiple questions here again, but I'll start with conjugated. Conjugated just means attachment. So you're actually conjugating two things, a protein and a carbohydrate or a polysaccharide, same type of molecule. So pneumococcus has that fuzzy coat that I showed. They take that fuzzy coat and they actually put it on a protein carrier. So when it's presented into the body as a vaccine, the body gets confused and makes an immune response more towards a protein, which is a different type of response than against the carbohydrate. So it's a trick that we play to get better responses in infants. So several of vaccines are conjugated. Hypogammaglobulinemia, same, different than CVID. Now this gets into definition and controversy, and by definition, common variable has two classes of antibody that are less than 2 standard deviations, below the mean. So it's a definition. It's a group of disorders. It's not one thing. Hypogam, some people will strictly say only if it's just IgG. That's low. And you don't have another class, so you really can't call it common variable. Is it a different gene? Well, same gene might cause both things, and it's a terminology discrimination. It may not be a genetic importance. It does become important when you're dealing with insurance companies, though.
I have lots of others.
Okay.
This one's pretty straightforward. How long does a patient have to be off gamma globulin or IVIG in order to get new vaccinations to recheck titers? Normally we'd like to have the patient off at least 4 months. Some of my colleagues say 6 months, but I think 4 months is a reasonable amount of time. Remember, the half-life of IgG is 23 days, plus or minus. So 4 months is probably suitable in order to reevaluate the antibody response of a patient. I'll give you the next one after this. I'll give you the complicated ones. Do steroids help antibodies work? Do steroids help? I don't know if it's antibodies or antibiotics work faster during sinus infections. Well, we use topical nasal steroids actually to decrease the congestion in the nose to allow better drainage, because drainage is good. So if a patient has enhanced drainage, after giving them antibiotics and using topical nasal steroids, I always tell the patients that's what to expect, and that's a good sign. Because sometimes patients think they're getting worse if they have more drainage, and particularly the back of their throat. But that's what we want to achieve by using topical nasal steroids to get actually improved drainage.
What about for the oral area?
Some physicians use that as well, particularly if they have underlying allergies, if they have allergic rhinitis, allergies in the nose. That's a quick way of, because actually it takes about 5 days for topical nasal steroids to have their effect. So if somebody's really congested, you look in the nose and everything's blocked up in there, we know that the topical steroids is not going to get back to where it needs to get, and so we'll use a short course of oral steroids to kind of jumpstart. I mentioned about kids, remember? About kids outgrowing it, but then it's different with adults, maybe different with adults.
I think the question here is that we shared that some children will outgrow specific antibody deficiencies, and the question is whether adults can do the same thing. Well, the only thing I've learned about the immune system is that it changes, and in general, I'd say the answer is no. After you reach maturity, if you have problems making specific antibody, it's usually lifelong. That said, I suppose there are times when things change or improve. Now, environment plays a role, and there's a lot of other factors, so it's not so clear-cut. But in general, if you haven't outgrown it by 7 years old, it's unlikely that you will.
Okay. This mentions complements, so I'm going to give this one to you.
Okay.
But,
how do we improve or assist physicians to better screen for GAM and subclasses to help diagnose immune deficiencies sooner? What complement tests do you suggest ordering? And the opinion of IgA subclasses. So there's several questions. The first one is, how can we help physicians better screen? It's difficult. It's hard to tell someone to do something when it's only part of the puzzle. So, physicians can screen antibody levels, but to interpret them in the context of the clinical is something that you need some experience. So it's difficult to know, but I think educating doctors to know and think about pace of infection and when you think about immune deficiency, and do some simple screens. But if you don't find it, don't just give up. If you still think there's an immune problem, refer them to a center. So I think I believe that people that deal with immune deficiency should be the ones to make a diagnosis, and not just every doctor, but every doctor should think that and know that there are immune deficiencies, because a lot of them just say, oh, those are rare things we'll never see. It's just not true. What complement tests do we do? There's three tests that I do C3 and C4 because those are consumable. And if they're both down, I more think that a complement's being consumed in the blood. And then I do something called CH50, which if that's low, then there's a deficiency in one of the proteins in the complement cascade, and then we start to look for what they are. Some people will do something called an AH50 that looks like at the alternate pathway, and that also sometimes used. I don't generally do that to start with unless I'm really suspicious. So you kind of do a screen, and then you start honing down on which protein. And these are tough tests because you shake the blood outside the body, and you can activate complement. It's very active protein. Opinion on IgA subclasses. I do not know of any relevance. I know there's a lot of labs that will measure these things. You can measure them. I'm not aware of any clinical correlation with an IgA subclass determination. Maybe Mark knows.
Okay, this is a good question. I'm sure Ralph has some comments too. When should we be retested? If I'm already on IgG, I assume replacement therapy, do we really need to know a more specific diagnosis? So yeah, I see a lot of patients who have been on replacement gamma globulin for a long time and carry a diagnosis of common variable immunodeficiency disease. And of course, I'm not going to take them off gamma globulin to reevaluate their vaccine responses. I just don't think that's appropriate. However, I think, as Dr. Shapiro mentioned, we now recognized, 320 different genetic abnormalities that are associated with a variety of type of immune deficiencies. But more importantly, probably for the majority of the patients sitting here, is that we've recognized a number of new genetic changes that are associated with the clinical presentation consistent with common variable immunodeficiency disease. And some of these genetic changes, mutations, if you will, allows us to understand what the associated comorbidities are. But more exciting than that, it allows us to perhaps even consider adjunct therapy or additional therapy that's directed towards the immune pathway associated with that particular genetic abnormality. And I know there's some lectures here that are addressing this, and other Troy Torgerson, I think, is giving a lecture directed in that direction. Hopefully it hasn't happened yet. Maybe it's this afternoon. So we live in a kind of exciting times because in some patients who carry diagnosis of common variable immunodeficiency, yes, we can take care of their infections by using replacement gamma globulin and perhaps prophylactic antibiotics, but they're still having some of these other disorders, mainly autoimmune disorders, that now, understanding the pathways, we can select the appropriate biologic that can address these autoimmune problems. You may want to expand on that.
Yeah, specifically looking at the ANA to know if it's from your IgG. Is that what you're asking? Because I've seen doctors misinterpret that. You don't get a positive ANA on immunoglobulin. That's new. So.
My doctor said to me, my primary said to me to a rheumatologist to figure out what's going on, but I was tested 2 years ago. But, do I really need to get off, figure out exactly what it is before I get the...
I don't know why being on immunoglobulin would affect the workup for an autoimmune issue, because you don't have enough autoantibody in the passive antibody we're giving to interfere with the testing. And to get at the cytokine issue, there's a lot of new drugs that are being made that affect certain parts of the immune system. And when you have an immune disorder and you have complications that aren't just antibody problems, like bowel problems or joint problems or skin problems or whatever, a lot of times it's from an immune reaction that's out of control. And using these drugs along with it has really made a difference in the care for patients with complex immune problems. So we use a lot of different biological therapies along with the immunoglobulin. It's very expensive, but it's very effective. And by making a genetic diagnosis, there are certain genetic diagnoses that have specific therapies that really have worked well. So genetic diagnosis is starting to become useful in certain situations where we can actually make therapeutic decisions based on it. So I think it's changing right now. We're in a transition time, and getting insurance to pay for the genetic diagnosis is where we're sticking right now. So we have to show the benefit, and so we're doing the work trying to do that now.
A question about getting live, viral vaccines in patients with underlying immune deficiency or diagnosed immune deficiency. I mean, as you know, of all of you probably know, it's not recommended to get live viral vaccines in patients who have been diagnosed with an underlying immune deficiency. I mean, it's in all the package inserts. This has been prescribed by the CDC, et cetera, et cetera. However, I must say that one of the most common questions I get in the older patients that I take care of with CVID is, should I get a shingles vaccine? So the shingles vaccine is a live attenuated varicella vaccine. And it's an excellent question because shingles is not a trivial problem. And so we're at USF, together with my colleague Dr. Lighting, we're actually doing a study to look at whether certain patients, let's say who have a diagnosis of common variable immunodeficiency, that have normal T cell function that we've measured in the lab, can respond to the shingles vaccine, and whether they don't have any consequences by giving them the shingle vaccine. So we don't have enough data yet, so it's a little bit early to give you any advice. But right now, the recommendation is to avoid live viral vaccines in patients with underlying immune deficiency. I'm going to give you, this is a difficult one. I'm going to give you this.
How would you evaluate if a parent or patient refuses vaccine? Well, we can't use vaccine to evaluate immune response, so it's a little more challenging. There's a couple ways you can do it. Naturally occurring antibody against carbohydrate happens because red blood cells have sugars or carbohydrates on their surface. We call them A sugars or B sugars, and that's the type of blood you have. Some people have no sugar, so they're called O. So if we look at something called isohemagglutinin, it tells you. So if you have A sugars on your red blood cell, when you see the B sugars that are on bacteria in your bowel, you make antibody to them. And so we can use that, but that's a pretty profound response. And we see people with normal isohemagglutinin that don't respond to carbohydrate vaccine. So when you see low isohemagglutinin, it's a more profound defect. So that's one way we can screen. You can look at naturally occurring things. And I don't use these a lot, but naturally occurring antibodies against things like Candida or other molecules. I mean, you can use them, but it's not as good. It's better to evaluate if you know they've had exposure, patient, and you see if they respond. So without vaccination, you're a little handicapped doing that. IgA deficiency can be normal in a lot of people without causing infectious immune deficiency disease, right? And that's true. If you look at blood bank samples of healthy individuals, you see it's fairly common to have no IgA. And so just having a low IgA or absent IgA may or may not be important, but we know that people with low IgAs can fall into one of three groups. They either have no infections, they have infections, or they have autoimmunity, or some combination. So IgA deficiency is a term that's misused a lot. I think if you say selective IgA deficiency, you should have it measured down to 0, and you have no IgA production at all. And I think those tend to be more severe than people that have some IgA production, and it's just low. And it may be the hallmark of some broader immune problem, just like we talked about with IgG subclasses. You can't just use that value alone to determine, what's wrong. What disease is neoantigen against? Neo means new. And so when we talk about using a neoantigen, it's something people haven't been exposed to. So when you use something like the phage vaccine they use in Washington, that's something people don't normally encounter. So you can actually see a novel immune response in someone because they haven't seen it. That's what a neoantigen for a vaccine is, something that people don't usually have in their body that we give to see if you respond. It's a way to provoke the immune system.
So just to follow up on that, the reason why the clinical immunologists are looking for neoantigens or novel antigens, antigens to which the individual has not seen before, it means that the antibodies are not in the gamma globulins. So it could be a worthwhile approach in individuals who are on immunoglobulin replacement therapy already, and the question comes up, do they still need to be on immunoglobulin replacement therapy? And as I said before, when I was talking about the 4-year-old who may outgrow it, I take them off for 4 months and then reevaluate them. Well, if we had a neoantigen, that is a vaccine to which the antibodies are not in the gamma globulin normally, then we can actually immunize that individual while they're still getting replacement gamma globulin and then evaluating their response to that, quote, neoantigen. So that is the Phi-X174 is in Seattle, but the rabies antibodies are not in gamma globulin. So that's like a new antigen, neoantigen. And it may be, when we get more data, be useful in actually retesting individuals in which we don't necessarily want to take them off the gamma globulin for 4 months while we're doing this repeat immune evaluation. Oh, someone asked about recommended doses and drugs for prophylaxis. As I mentioned before, I use Bactrim or azithromycin if somebody's soft allergic. So the Bactrim is usually half the treatment dose daily. The azithromycin, at least I use it 3 days a week. There's other variations on the theme, but 3 days out of the week. But there's other clinical immunologists may have other variations on that. Trying to find it up.
Do you worry about long-term antibiotic use? This comes up when you recommend someone go on a prophylactic antibiotic because you're on it for a long time. And I think the reason we select certain antibiotics for prophylaxis is trying to get around the trouble with broad resistance. So if you select an antibiotic like Bactrim, then you treat someone who gets infected on Bactrim with a different class of antibiotic so that you kill the bacteria that are there, because the ones that are on you are the ones that can live in the face of that prophylactic antibiotic. So by doing that, I don't think we create new resistance. A lot of the press about antibiotics are really dealing with population. So in a population, if you overuse antibiotics, you develop bugs that are resistant, and then that can become a problem for those that need the antibiotic. So we select, I use amoxicillin, which is not a very good antibiotic to treat infection because most bacteria are resistant, but it works really well for prophylaxis as a starting point, I think, and we don't know what's the best. I do use Zithromax 3 times a week or Bactrim once a day. Those are common approaches that seem to be safe for long-term use. Yes? Yeah, Augmentin is a combination drug. It gets around the penicillin resistance. It blocks the enzyme. So it's a little broader, and it covers a lot of different bacteria, and it will alter the bacteria in your bowel. So I don't use Augmentin much for prophylaxis. I just like to save that for treatment. Ceftin is a cephalosporin. That could be used for prophylaxis. I generally don't. It's a little broader again, but I don't know why it couldn't be. It could be in someone who's highly allergic. It's an alternative.
What's your opinion on the study that some years ago that Bactrim can lower the neutrophil count?
Bactrim, when it first came out, there was concern because some people would lower their neutrophil count. Their bone marrows would be suppressed. It's a very rare problem. It has been reported, and you look at the label on almost every drug and you see the list of things. It's a very common thing to be listed. And it doesn't mean it happens very commonly. But yeah, so Bactrim can suppress the bone marrow in certain individuals. It doesn't usually. It also can photosensitize you, so you have to be careful out in the sun. So sometimes I won't use a sulfa drug in someone who's in the sun a lot. Just because you can have problems from. Doesn't mean you will, but you can.
So just a couple more comments about I never use an antibiotic prophylactically that I'm going to use as treatment. So Augmentin is a good antibiotic to use as treatment, so I will not do that. And the same with the second and third generation of cephalosporins. Since I might use that antibiotic as a treatment for, say, bronchitis or sinus disease, I will not use that as prophylaxis. The data on Bactrim actually goes all the way back to chronic granulomatous disease. So we have a lot of data on using Bactrim or Receptor. It is not a good antibiotic for treatment, however, of an infection, but it turns out to be a very good antibiotic for prophylaxis. The azithromycin data stems from the literature on patients with cystic fibrosis, where pulmonologists found that using azithromycin, whether it's 3 times a week or a variation of that, was also a very good prophylaxis in patients with cystic fibrosis. So there's very little data on prophylactic antibiotics outside of chronic granulomatous disease or outside of cystic fibrosis and some of the other chronic lung diseases, but I don't use treatment antibiotics as prophylaxis.
So would you say that like a choice for somebody allergic to like so many different prophylactic drugs, this amount would be probably the best alternative?
Yeah.
As opposed to say Augmentin or something like that.
Well, Augmentin is a penicillin derivative, so I mean, if they're allergic to Augmentin, they're going to be allergic to.
I'm allergic to like Bactrim.
Oh yeah, then right,
So this amount would be like that would be your first
right,
choice.
right,
Or amoxicillin.
Or just straight amoxicillin.
or amoxicillin, right, exactly. My son with antibody deficiency memory type, can he outgrow it? I don't know. We don't have very much information or data with regard to the memory phenotype and you know, in different age groups. I think it might be worth, depending on, you know, I can't answer this totally because I don't know the patient, but it may be worth doing this once to take the patient off immunoglobulin replacement over the summer and then reevaluate. Because after all, you're taking this 12-year-old and you're kind of committing him to a long-term gamma globulin treatment. And, you know, all the issues, social issues that are involved with that. So I think it's probably worth at least one time the patient with this memory phenotype, even though he's 12, to take him off over the summer and then reevaluate to see if he still has that diagnosis. That's my opinion.
I'd agree, and there's an anecdote I have. I had 2 children in a family that had memory problems as a kid and were sick a lot. And as they got to be 5, 6, 7, they started doing better. and I lost them to follow-up, and I just saw one of them back at 17 now, and she still doesn't make good antibody to vaccination. Her pneumococcal titers, she had about 4 or 5 out of the 23 with protection. So she still has the problem, but clinically she's been totally fine. She came in for a different reason. She had low platelet count. So there's probably something wrong in her immune system, but she's not having infection. So it happens, and I don't know that you really outgrow it, or you just develop more compensatory mechanisms and handle it differently. What other testing could be done if you have very low IgG and not good response to Pneumovax? There's a ton of tests you can do if you want to spend a lot of money. It really depends on how much you need to know and what level you want to look. There's also controversy on low levels of Ig. If you have low levels of Ig and don't have a lot of infections, should you replace? And is there a level that everybody replaces? So we do not know the answer. And so if someone has a level of IgG that is 300 and is healthy, it should be over 700. Should that person go on a replacement? And it's controversial. We really don't know. That's where these qualitative types of tests help, and it may help to look at phenotyping and other things. I just want to tell a story a little bit about some of the experiences I've had with people that we debate whether we should treat or not with low levels of antibody. If you don't make antibody to pneumococcus, you may be totally fine for many years, because the pneumococcus get in you, they cause snot, they cause cough. But if pneumococcus gets in the wrong place in you, you don't have any way to control it. And pneumococcus can be deadly. It grows very fast, and people can start with a fever in the morning and be on a ventilator at night in shock. And so I've experienced through my career several patients over time that had recurrent sinus infections, not terrible, never got diagnosed, and then they get bacteria in the blood, and they go into septic shock, and they lose their limbs. And you look at them, and they can't make any antibody to pneumococcus. Well, if you knew about that ahead of time, I think you're doing a disservice not to protect them for something that serious. So if you can't get pneumococcal antibody, I really think you have to stay on a prophylactic antibiotic, and I like penicillin for that because it covers 95% of pneumococcus. Or you need immunoglobulin. And so I think looking at the other tests really are instructive, and it's scary and difficult when you have a patient that looks you in the eye and say, I'm not sick, why are you going to put me on immunoglobulin? So it's difficult as a physician to look at someone and recommend a therapy that's that difficult and expensive when they're sitting there healthy. But it really depends on your risk. How do you lower the risk for something serious? We all wear seat belts because we drive around. It's not because you're likely to have an accident on that day. It's that if you did, it's that serious. And I guess that's how I look at replacement in people that don't make good quality antibody. I don't know if you have a different approach.
I don't think that's fine. Okay, last. The nature of infections in a patient with specific antibody deficiency changes, and the infections become more prolonged than recurrent. What are your thoughts? Again, I think we need to look for possibly other circumstances for the change in the clinical progress of this patient. I assume they're on immunoglobulin replacement therapy, so we need to determine whether that's adequate, and we can shortly discuss that. But find out if there's other comorbid conditions that are associated. We already talked about allergies, for example, or maybe there's obstructions in the sinuses that needs to be addressed, or maybe the diagnosis has changed. That's also possible. I don't know if you have anything to add. No? Okay. That was the last question.